Good evening. I'm Erin Beveridge, a clinical researcher, and on behalf of Canon, I'm delighted to be welcoming you to our fifth and final day of the online neurology days. So far, we've been looking very closely at diseases of the central nervous system, with sessions dedicated to both stroke and multiple sclerosis. However, neurology is more than just the central nervous system, so let's not forget about the whole of the peripheral nervous system and the many conditions that can affect this. And to make sure that we give this aspect of neurology the attention that it deserves, tonight we will be bringing you the best double act in the field of neuromuscular disorders to shed more light on this fascinating topic. Just before I introduce our speakers for this evening, I want to remind you all that all of our webinars are recorded and posted on the Canon Medical Europe website within the next 2 weeks, and you will all receive a certificate of attendance within 2 weeks. Now back to this evening. We are very fortunate to have two great speakers who have collaborated to not only share their expertise, but also their unrivaled passion for the use of ultrasound in neuromuscular diagnostics. Both speakers are very active in teaching and training on this subject, so I'm not only certain you will learn a lot, I suspect you will also leave feeling inspired. We will have an opportunity for discussion at the end, so please do make use of the Q&A function and ask questions throughout the talks. Now it gives me great pleasure to introduce our first speaker this evening, Professor Nins van Elfen. Professor van Elfen is an Associate Professor of Neurology and a clinical neurophysiologist at the Radboud University Medical Center in Nijmegen in the Netherlands. She is also the Medical Director of the Clinical Neurophysiology Laboratory and Coordinator of the Clinical Neurophysiology Residency Training Programme. Her areas of expertise are neuromuscular ultrasound, peripheral nerve pathology, brachial plexus neuropathies, and electrodiagnosis of neuromuscular disorders. Her current focus is on advancing muscle ultrasound and developing a national teaching and quality programme for neuromuscular ultrasound in the Netherlands. In fact, it's already the case that clinicians come from all over the world to join her training programmes, which makes us exceptionally lucky to have her share her knowledge with us this evening. And with that, I pass to you, Professor van Elfen.
Thank you very much, Erin, for the wonderful introduction and for the reminder that there is more to the nervous system than just the central nervous system part. Thanks again for the invitation to talk to you all about neuromuscular ultrasound, which Dr. Borchert and I think is a true game changer for your PNS diagnostics. My name is Nens van Elfen, and this is the hospital I work at in Nijmegen, the Netherlands, which is not the prettiest building, but it's a very good place to practice and teach and learn muscle and nerve ultrasound. And showing you this, I would like to start with the why. Why should we perform neuromuscular imaging? Well, basically, it's simple. If you are a neurologist and you have a patient you suspect of a central nervous system lesion, the first thing you're probably going to order after the clinical exam is a scan. And we can make beautiful images of the brain, the spinal cord, tractography as shown here. But when we get out to the peripheral system, there really is no reason why we shouldn't make equally beautiful images from muscles, nerves, movement, anything goes. So we don't have to stop at sticking needles in people and putting current on their skin. We can also make beautiful images, and they help. And for me, neuromuscular imaging is like this Swiss Army knife tool. It's a very versatile technique which allows you to do a lot of things for your neuromuscular patient. So you can not only look at the lesion and localize it exactly, but you can also see what surrounds it and what the nature of the lesion is. And it's very easy to screen multiple regions in the arms or the trunk without pain. And you can do that at the bedside, but you could also do it in your outpatient clinic. So ultrasound is also easy in capturing motion and movements, both voluntary or involuntary. And if you want to, it can also help you guide your invasive procedures, like sticking an EMG or a biopsy needle in at the right place. And the good thing about it is that neuromuscular imaging is actually the new kid on the block compared to EMG, obviously. And therefore, a lot of effort has already gone into proving scientifically that this has value for your practice. On the next slides, I will show you just a few examples of review papers that have come out in the past couple of years talking about all the advantages and the techniques that we use in the neuromuscular ultrasound community. And I don't imagine that you will remember all of these at once, but just to show you the volume of research that's been going on to see what actually is useful for your practice. And I really like the paper in the lower left there, which looked at the cost value, saying that this is a very good bargain for your money, and for the patient and the healthcare system as a whole. Now, why do we call it a game changer? Well, let me start off by this case example. I'll take you through this throughout the rest of the presentation. So this was a 31-year-old female. We saw her very recently. She was referred by our plastic surgeon, and he sent her because she had undergone 3 embolizations of a supraclavicular venous malformation. And they had been performed because she was complaining about arm pain and fatigue, but instead of decreasing her symptoms, these procedures actually increased her symptoms. And then the multidisciplinary clinic that treated this vascular malformation said, okay, we can't apparently do any more embolizations. It's not helping. So we're now going to refer to a surgeon to cut this thing out. But the plastic surgeon said, wait, I don't understand. What is the pain, the relation between the pain and that residual really tiny vascular malformation she has left? And so he forwarded the lady to our clinic and said, please, can you both evaluate the patient and the nerves around that vascular malformation? And that is what we do very often. As you, as a doctor, are the one scanning, we also talk to the patient, we examine them, and then we do the ultrasound to sort of round up the whole analysis. Now, just to start us off with this case, here are some standard radiology images of that venous malformation. And this was a direct puncture. So it's not an intra-arterial or venous line, it's a direct puncture. And after that 3rd attempt, you see there was a really tiny residual malformation left of 11 millimeters length. Now, we too felt that this tiny residual lesion was not enough to explain all her symptoms. And she was in continuous pain, very severe, and she couldn't use the arm anymore. So what do you do as a neurologist? Well, obviously we start by taking a new history. And the lady told us that after the first 2 procedures, she had pain for a couple of days, but that went away real quick. But then after that 3rd embolization, she actually had an NRS pain of 9 out of 10 for over a month. It was unbearable. And since then, she hadn't been able to lift her arm. And she also noticed that her arm fatigued real easily. And she had pain of the muscles in the neck and shoulder region on the left. And when we looked at her shoulder, it was apparent that something was wrong because the whole shoulder was very tense. It was extremely painful upon palpation. Movement was less to impossible. It was dyskinetic, meaning that the movement was not supple and normal anymore. And we had the impression that the deltoid muscle was paretic, but it was really hard to test her because of all that pain. So let's scan the lady and see some pictures, right? Well, to do that, let us first start with introducing you to what nerve ultrasound looks like. So here is the nerve. And I think if you can appreciate the histology image that's on the lower left there, that's the sural nerve under the microscope, and you make an abstraction of that in your mind, then you can see the median nerve in the middle of that ultrasound image on the right. It's an oval or round or triangular structure. The shape sort of depends on the room it gets from the muscles and the ligaments that surround it. And if you happen to be a surgeon, an ultrasound nerve looks like a nerve that you've cut or someone has. Now, here's a very common example. This is a median nerve in the forearm. The arrow is pointing at it and it's wedged in between those 2 flexor muscle layers. And what we do in neurology is that we measure the nerve and we use what's called a CSA. It's a cross-sectional area measurement. And we always measure within that white hyperechoic rim the nerve has, because that's the most reproducible way of analyzing and gauging it. Here's another example. Now we have twisted the probe 90 degrees around, and it's a longitudinal image of the median nerve, that rather dark structure that runs into the carpal tunnel. And you can actually see the carpal ligament. The arrow is pointing at the proximal edge of it. And it's good practice that if you see an abnormality, you also image that in a longitudinal fashion. Here is a short practice demo of what that may look like. So this is the median nerve being scanned there. There's a black hole next to it, which is actually a persistent median artery. This is a normal, healthy subject. You see the two bones that define the entry of the carpal tunnel. And beneath the nerve, you can see the different flexor tendons. And so we freeze the image here. And now a measurement tool is put inside the hyperechoic rim to measure that cross-sectional area. This was about 7.5 square millimeters, which is perfectly fine. There are reference values for the population for this, which you can use. So let me show you a couple of pathology examples for that median nerve. So for reference, on the right of your screen is a normal median nerve. That's the one you just seen. And the same image depth is on the left, but you can now see that the nerve is much larger there, and it's kind of darker, hypoechoic. If it's hard to see, here's the nerve. So I'll go back and forth here, and you can appreciate the size difference. And this one's abnormal. And that is actually just carpal tunnel syndrome. But on this next image here, again, a normal nerve on the right and the pathology on the left, you can see the median nerve more proximally in the forearm between the flexor muscles. We are not near the carpal tunnel here, and still it is enlarged. So if we look closely, you can see that every fascicle is actually bigger than it should be. And this is a patient who had a slightly rare, but a Noonan syndrome, which is an overgrowth syndrome where your nerves and more tissues in your body will enlarge. And this is a grossly enlarged nerve because of that Noonan syndrome. So next, I'm going to show you the value of dynamic ultrasound. And this is just a median nerve with someone who starts doing typing movements, and just see what happens to it. So that's the median nerve, the flexor tendons, and you can see the nerve being pushed and shoved around while the person is performing a typing exercise. And actually, every time I look at this video, I feel sort of sorry for the nerve when I think about what I'm doing to it all day at work. You know, it's getting kicked around, and it's almost strange that not more of us have carpal tunnel syndromes, right? If you see this. Here's another example of dynamic ultrasound in a video. This is a ulnar nerve just proximal to the elbow in this image. And because this person has a slightly higher BMI, the subcutaneous layer, which is this whole area, is larger, but also more hyperechogenic, so white. And actually the nerve is right here embedded in the triceps, which is this muscle, and you can see the edge of the humerus. And when I start the video, we're going to see that nerve moving next to the medial epicondyle. So we're at the level of the sulcus entry here. And then you see a lot of probe movements because you have to twist the probe around to keep this nerve in view. There's the ulnar nerve in the cubital tunnel. And now it's below those two halves uniting to one flexor carpi ulnaris muscle. So there. So this is an example of dynamic ultrasound scanning. And this gives you a lot of information about the pathology and the relation to its surroundings. Now let's go back to that unfortunate young lady with the venous malformation. We scanned her brachial plexus, and in neurology, often we use the interscalene and supraclavicular view to assess the plexus. And in this lady, we're also going to go to the infraclavicular region for a bit. So I put two normal looking images of the interscalene plexus. You see the little balls of nerve elements stacked on top of each other here between the anterior and middle scalene muscles. And then in this lower image is the first rib, subclavian artery. And then here is sort of a bunch of grapes, and that's the brachial plexus in the supraclavicular region. Now, in this lady, let's, for reference, look at her C5 root exit. So I've highlighted it there. You can see the transverse process. It's this basket-shaped structure, and the nerve root is exiting from it. And when we measure it, it was 7.8 square millimeters, which is normal. So just as a reference, any further distal structure in the C5 distribution shouldn't be larger than the root it originated from. Now here is her supraclavicular plexus. So again, I've put some anatomical annotation here for you. So you can see the first rib, the subclavian artery, and then that bunch of grapes, the nerve structure right next to it. And I think you already see that one of the superior trunk elements is rather enlarged. It's encircled with a yellow line there. And when we measured it, it was indeed larger than the other elements in that plexus. So that denotes abnormality here. And then we looked at the relation between this enlarged superior trunk element and her venous malformation. And this is using the superb microvascular flow imaging option in this machine, where you see a residual flow element here, but that is, in anatomical terms, is really a long way from the plexus. It's not in direct contact, so to speak. So you can't really say that there's any direct influence of this small structure on that element there. We scanned further and skipped over the clavicle. So this is the infraclavicular plexus now. And you see this subclavian artery here, and then the lateral cord here with the reference measurements, which is okay. But then the posterior cord was much enlarged and surrounded by some hyperechoic, fibrous, probably scarring tissue. So this young lady had what we think is an iatrogenic superior trunk lesion that crossed over into the posterior cord, which happens to be the nerve element that innervates the deltoid muscle and some of the extensor muscles in her arm. There is no direct relation to that venous malformation anymore. So we have no idea what happened during the last procedure, but something apparently sort of, damaged this brachial plexus element. But with this finding, you can't find an indication for renewed surgery. So the plastic surgeon was right to be very careful here. And because of her severe movement impairments and the dystonia and dyskinetic movement pattern, she was referred for specific shoulder rehabilitation. And the nice thing is that you see this lady, you can talk to her, do your physical, and then immediately, without any pain or the need for needles or current, you can see what the lesion is and refer her to the correct treatment. So we think this is a game changer because it's very convenient and very friendly for your patient, actually. Now, let me show you some of the diagnostic values for nerve ultrasound that's have been published in the literature over the past, I think, 20 years. If you look at entrapment neuropathies, so carpal tunnel syndrome, ulnar neuropathy, the most compact summary would be that they are just as good as your electrodiagnostic exam. But if you combine them with EMG, you are most sensitive to detecting this particular pathology. So in case of carpal tunnel syndrome, both ultrasound and EMG will pick up 9 out of 10 patients. But if you combine it, you will pick up 95 out of 100. And so it's up to you to decide whether you think that's helpful in the case that's before you. We know that for trauma, compared to regular MRI scanning, nerve ultrasound is much more sensitive because the actual resolution, especially in those superficial 4 centimeters, is much higher than for MRI. And so this is obviously, if you go to very deep regions like the lumbosacral plexus, you need another type of imaging. So we advise MR. But if you look at limb nerves in the upper or lower extremity, ultrasound is superior for that. And another good thing that will also be put in the next or the new guidelines of the EFNS is that nerve ultrasound, a very limited protocol scanning a median nerve and a brachial plexus, is already very sensitive for picking up an inflammatory neuropathy, where you see multifocal thickening of the nerves. And the good thing is that the nerve ultrasound is really sensitive to pick that up. And if you then want to confirm what type of inflammatory neuropathy it is, you can add a very selective EMG exam to look if it's CIDP or MIDN, for example, or MMN, if that's not clinically obvious. Now, you see here that the sensitivity of ultrasound is high and the specificity of EMG is high. So the best thing you can do is use them in a stepwise fashion. And the good thing is that if you take that approach, you will find 20% more patients who have a treatable condition, and that is good for your patient. Now let's talk a little bit about muscle ultrasound. That is basically a story of 256 shades of gray, meaning from totally black, which is 0, to 255, which is completely white. Now here you see an example. This is a side-by-side image example of the calf muscles. I've put some anatomical markers in here. So it's the medial gastroc. And you can see that the one on the left is normal. You recognize it as muscle tissue. Basically, it looks like a cut slab of meat. On the right, something's going on because the muscle is really white, is dense, there is no more architecture, and it's also thinner, so there's atrophy. And this is what a muscle looks like that's been completely denervated, for example. So this is a denervated calf after a hemi-cauda syndrome. Now, why is it getting wider? That is because there are much more reflections in a pathological muscle. So here you see two examples of tibialis anterior, and the one on the left is normal, and the one on the right is from a patient with FSHD, facioscapulohumeral dystrophy. And in a pathological muscle, there will be many transitions between normal muscle tissue, fat, fibrosis, then again, maybe some muscle. So a lot of reflections leading to a very white image. And also these dense top layers, they already catch a lot of the ultrasound energy. So not a lot is getting through to the deeper areas. So you can't really see through that muscle anymore, which you can do on the left. Now, if you have this concept in mind, I think you can understand why this grading scale has been developed. Because already in the 1980s, Sidney Heckmat developed this muscle echogenicity grading scale using a system of 3 axes. So one is, can I see its muscle tissue, or is the texture or architecture still intact? And then the second axis is, how white is that muscle? So is the whiteness increased because of a lot of tissue transitions in pathology? And the third axis is any ultrasound getting stopped by these dense tissue transitions? So is there attenuation, as it's called, of the beam? And if you combine those, you get this grading scale from a normal looking image that is nice and dark, and you can see the underlying bone on the left, to a completely white fibrotic muscle, which you can't see through anymore on the right. Now, there's more that you can do than just look at the echogenicity, because there's also patterns of abnormality. So here you see 3 examples. The one on the left is a very typical appearance for a primary dystrophy or congenital myopathy. It's like someone took a pen, colored the muscle, and then rubbed it out with an eraser. And that diffuse aspect is very typical for, in this case, it's also a dystrophy. While in the middle there, you have an image of the forearm flexors, and the arrow is pointing at the flexor carpi ulnaris. That's a nice oval muscle. But in this case, one half of it is quite white and the other one is dark. Well, the white part is abnormal. And this is a very common focal pattern you see in inflammatory myopathies, such as this myositis patient. And it's handy to know this if you want to do a biopsy, for example, because you want to take a biopsy from the abnormal part, not the part on top. And then on the right, you see a very specific pattern that's typical for long-standing neurogenic changes with reinnervation occurring. So it's been likened to a moth-eaten appearance or a Swiss cheese, and the holes are actually remaining viable motor units. And this is a patient with spinal muscular atrophy who has very few large motor units left, and the rest is fibrosis. One of the other nice things, again, is that you can see dynamic imaging or videos. So this is clearly an abnormal looking biceps brachii and brachialis muscle in the upper arm. And you can see that the muscle layer here is much wider than the subcutaneous fat, which is not okay. And when I start the video here, you can see all these little tiny jerky movements that you can't really predict. So you have no idea when the next one's going to come and where it's going to be. That unexpected aspect and the fact that it's a chunk of muscle that's moving is very typical or pathognomonic for fasciculations. And because this video has a capture area of 4 by 4 centimeters, you can sort of see that this is much easier to pick up fasciculations than with a very tiny needle tip of your EMG. But we can go smaller. So this is an ultrasound video. It's slightly zoomed in of the rectus femoris. And this is a patient with acute myositis. And if I start the video, then you can see in that top layer of rectus femoris very tiny trembling movements. And that is fibrillations. And if you have a lot of them, you'll be able to see that with ultrasound. If you have a high enough frame rate, so this one is at 20 frames per second, and you need to turn your smoothing software off on the machine. But these are really there. And if you were able to sort of take the skin off, subcutaneous layer off, and the fascia off, you would also be able to see them with your bare eyes. I always show this video just in case you think, okay, this is nonsense. This is a denervated extensor digitorum brevis muscle. We did that for another purpose. We did it with botulinum toxin. And then we stuck an EMG needle in and put the ultrasound probe over it. And if I start the video, it's time locked with the ultrasound. So I hope you'll be able to hear this, but you see the movements and you hear the fizz. So they are fibrillations that you're seeing. Now, here are some of the muscle ultrasound screening values from the literature. If you're just eyeballing the muscle and you say, okay, I think it's abnormal, your sensitivity, if you have a bit of experience, will be around 70% for detecting abnormality. But if you use a quantitative technique, such as giving a number to the gray level that you see from 0 to 255, and you use a very standardized analysis method, then you will get sensitivities up to 95% with very high predictive values. And that is very good for practice. So you can actually screen people with this in a reliable sense. If you have a classic neuromuscular disease, such as SMA type 2 to 4 or Duchenne's muscular dystrophy, you do not need to worry. You will always find abnormalities in these patients, even if they're very young. And in Duchenne, it's been proven that you can even find it in the pre-symptomatic stage. Now, if we use it for ALS, we already talked about the fasciculation screening. You will find about 20 to 30% more fascics with ultrasound than you do with EMG. And you can use ultrasound, even fasciculation screening and eyeballing the muscle to get to the diagnosis if you compare it to relevant mimics. So we've performed a quantitative study with these really high diagnostic values, and that's similar, again, to EMG. But I think the best thing for your patient is to combine the techniques, because if you do EMG and ultrasound, even if it's just fasciculation screening, you can put about 25% of your patients in a better and more certain diagnostic category. And those patients don't want to know if they have probable ALS. They want to know if they're going to die or not, basically. So it's really helpful in practice to combine them. And then finally, but not the least, if you're looking for phrenic neuropathy, I would say look no further but just put the ultrasound on. Because in a large study that was published a couple of years ago by the group of Dr. Boone in Mayo Clinic, they found that ultrasound was actually more sensitive than lung function testing, fluoroscopy, and the EMG. And it's much more patient-friendly to do it like this, and has really high predictive values. So one of the recommendations I would like to give is that you screen kids with ultrasound, because and this maybe also goes for patients with mental handicap or other limitations to the exam, because it is a good screening technique. And just to show you one more example of why we think it's a game changer, this is a young girl. She was 11 years old and she loved her horse, but the horse one day got really frightened and ran away into the stable, closing the door on her left arm and basically crushing the left upper arm. And so from that point on, she had a dropped hand and dropped fingers on the left side. We saw her a couple of weeks later, and there was still a paralysis to a grade 1 paresis of all these muscles. And she allowed us one needle stick with EMG, and that showed denervation. And no motor units. So now, but then again, she was also not very cooperative because she was very scared of the needle. So now the question was, is this nerve intact? Do we need to operate? Otherwise, she might not have a chance of recovery. So we're going to scan the muscle. And before I start the video, which is also annotated, I can tell you that this is the upper arm, lateral side. This is the humerus. This is posterior, triceps muscle, anterior, biceps muscle. Here is the radial nerve, and it's going to come over from the left to the right in the humeral sulcus. And you will see some scar tissue in this region where the door crushed her arm. Here we go. There's the anatomical annotation, the radial nerve. There's a scar. And here the nerve is becoming quite enlarged, but it is intact. So this is what a traumatic neuroma looks like. So it's a big swollen nerve in the area of acute mechanical pressure, but there's no discontinuity. So from this aspect, there's no reason to call the surgeon yet. But because we had to convince her pediatrician, we also examined her muscles. And this is an ultrasound video of the extensor compartment in the forearm with the extensor muscles of the fingers, so here and there's the thumb and the index finger muscles. And when we start the video, we asked her, could you please try and play the piano for us? And she did. And if you look closely, you can see that every muscle segment is actually moving when she tries to move. So every nerve element here is in continuity and still transmitting impulses. So this made the definite decision that there was no need for us to operate this girl because this is a crush injury, but with intact continuity, both externally, internally at this point. And so we waited and we advised her just to, go home, your body will take care of this. And it did, and she got better. So let me just sum up what neuromuscular ultrasound could do for you. It's a very reliable and proven screening method for neuromuscular pathology, so myopathies, but also neuropathies of different kinds. It can provide a more certain diagnosis for patients suspected of ALS at the time when they first present to your clinic. And it can also make a diagnosis when your EMG doesn't provide you any info anymore, for example, because there's nothing that you can record. And then you know the nerve is damaged, but you don't know where it is. It can also prevent you from sticking needles in places you don't want them to go. And it has been proven to be a good and sensitive biomarker for muscle dystrophies. So if you want to do a trial, this will show changes before the clinical status does at group level in Duchenne and in FSHD. And there's more. So once you have the ultrasound machine, maybe you'll find yourself looking for it when you need to do that lumbar puncture in a patient with a BMI of 35 or 40, and you can't find the midline. And ultrasound is also very helpful in that case. So if you would want to know more, then I can highly recommend this upcoming digital conference. You can watch it from the comfort of your own chair, just like you're doing now. It's a virtual meeting and it will be up from September 22nd to 24th. There's a course part, there's a conference part on everything neuromuscular imaging, both muscle and nerve, both MRI and ultrasound. So I really invite you to join us there. And with that, I would like to end my presentation and give the floor to Dr. Borchert for part 2. Thank you very much.
Thank you, Professor Van Elfen. That really was brilliant. Your case studies were so fascinating. And well, I can't imagine there are patients anywhere who won't like the sound of an alternative, non-invasive and painless diagnostic test. Now, to follow on from that wonderful presentation, I'm going to introduce our second speaker of the evening, Dr. Alexandra Borchert. Dr. Borchert works as a neurologist with special expertise in nerve and muscle ultrasound and clinical neurophysiology. In addition to her clinical work at the University Hospital Munster, she focused on neuromuscular ultrasound in the diagnosis of peripheral nerve disorder since 2007 and established this method in routine diagnosis. Since 2013, as a senior physician, she was responsible for the neurophysiology laboratory and neuromuscular ultrasound in Berlin. Currently, she works with a focus on surgery of peripheral nerves and reconstructive microsurgery at Pauls Kliniek in Aachen. This evening, she has several very interesting case studies to share with you. And with that, I pass the word to you, Dr. Borchert.
Thank you very much for the wonderful introduction, and thank you very much for the invitation. Yes, I'm a neurologist in Aachen. You already heard that, with a focus on nerve ultrasound and neurophysiology. And I am at the Pauls Kliniek in my daily routine next door with plastic and hand surgeons with a focus on reconstructive microsurgery of nerves and muscles. And so we see a lot of trauma patients and tumor patients. And I collected some cases for you to highlight possibilities of nerve ultrasound. So let's start with children. We already heard we recommend application in children because we all know children do not necessarily cooperate in EMG examinations, and with nerve ultrasound, we have a painless, fast, and very exact diagnostic tool, and children can easily be distracted by watching something on the screen. And so the first case is about a 5-year-old boy. He stumbled and fell while getting out of the car, and he was diagnosed with supracondylar fracture of the humerus, and K-wire osteosynthesis was performed. And afterwards, he had a median nerve lesion with numbness of thumb, index, and middle finger, and problem with grasping and holding something. And an EMG was recommended, but the parents refused because they heard this is painful and not easy to do, and so they preferred to have a nerve ultrasound. And what could have happened to this nerve? One of the most common trauma in children is the supracondylar humerus fracture with nerve lesion. There, the bony dislocation itself can damage the nerve, but also the repositioning and the osteodentesis can cause nerve damage. The lateral wire can affect the ulnar nerve very easily, and also the median wire may extend beyond the bone edge and cause nerve damage. So let us see the region of interest of this case. We are at the distal upper arm. There's the ulnar nerve, there's the median nerve, and here we have the cross-sectional view of a normal median nerve at this level with a typical honeycomb structure between the muscles. And in the longitudinal view, we usually have the fascicles arranged parallel with hyperechoic reflexes between the fascicles. And what we find in this case was we have the longitudinal view of the median nerve at the distal upper arm. Here's distal, here's proximal, here's the bone. And we can see that the distal part of the nerve is quite normal. And then here, something must have happened because here's a change in echo texture. The fascicles are hypoechoic and not easy to define and to differentiate here. So let us look closer. If we do so, we see here's the change in echo texture, and here is a bone defect in the longitudinal view. And in the cross-sectional view, we also see that something had come out of the bone and affected the nerve, because here the nerve is enlarged, hypoechoic, no honeycomb structure anymore. And so this was the K-wire canal. And so after removement of the K-wires, there was full recovery over a course of weeks, and nerve ultrasound was able to detect type, level, and extent of the damage and helped us define the therapeutic procedure. In this case, no further surgery was needed, but this can be different, especially if there is an interruption of continuity of the nerve, or if we find wedged nerve parts in the fracture gap. To get an idea of this, here's a longitudinal view of the median nerve at the distal upper arm after supracondylar humerus fracture. This is the median nerve. The fascicles are enlarged because the nerve is wedged behind the bone here. And so if there's no clinical improvement over time, this may be a situation where we have to do explorative surgery. The next case is about neuroma and also some technical aspects and its effect on the image. For traumatic nerve injury, there's the classification of Sunderland and Seddon. The more severe the tissue damage, the worse the spontaneous recovery. And if there is damage of tissue like endoneurium, perineurium, epineurium, this can cause a change in shape and size of the nerve, and a neuroma can arise. And if the outer epineurium is still intact as a kind of external guide, the neuroma will arise within this external guide. And this is a neuroma in continuity. And this we can find in our next case. This is about a 41-year-old woman after distal radius fracture in childhood, and osteosynthesis was performed. And since the removal of the osteosynthesis material, numbness of the dorsal thumb, index, and middle finger occurred, an intense tinal sign at the level of the scar at the radial wrist, radiating into the region of numbness. Over the years, the function recovered. And we want to know what happened to this nerve. So I introduce you the region of interest of this case. We are at the level of the wrist. Here is the superficial radial nerve and its terminal branches. And here is a cross-sectional view of the superficial radial nerve next to the vein. And so I can show you a short video sequence of this case. We have to focus on this spot because this is the superficial radial nerve. We can see the superficial radial nerve here, crossing the vein. Here in the bony structures, there's the neuroma, an enlargement, hypoechoic, and then again, an enlargement and the terminal branches with a normalization. And in the longitudinal view, here's proximal, here's distal. We find here a retraction and the larger portion of the neuroma in the proximal part of the nerve. And here, the nerve has the lesion, and the nerve was soon in during skin and tissue suturing. And over the years, reinnervation took place through this retraction zone. And because this neuroma is quite big, I would like to use this case to show you some technical aspects. This is a longitudinal diameter of about 1 centimeter and a cross diameter of about 3 millimeter. And so I used different presets and probes. And I start with a musculoskeletal preset. This is not focused on the nerve, about 8 megahertz probe. And we see the tissue components are quite blurry. We still can see this neuroma because it's quite large, but we only see very blurry structures. If we use a nerve preset focused on the nerve and a higher frequency probe, we see more clearly. We see well-defined the edge of the neuroma, and also the tissue components are more clearly. And with an even higher resolution with 24 megahertz and a nerve preset, we can see very well-defined the tissue components, the outer edge of the nerve, some informations about the inside of the nerve. And if we have a 33 megahertz probe, we also see the inner structure of the neuroma, which is quite impressive. And with this high frequency probe, we can still detect properly structures up to a depth of about 7 millimeter. And for superficial lesions, this is quite impressive. So this is a progress of technique, and we can see as a conclusion, technique has a great impact on the image quality. And in this case, we can see that even large neuromas of sensory nerve can have full recovery over time. This can be different in motor nerves because there the situation is more complex. Regeneration time and distance to the connected muscle do influence the outcome. And intervention may be necessary in case of motor function loss and insufficient regeneration. And depending on the region, we have certain time windows, and we can do the surgery within this certain time windows to have a good outcome. So surgery is needed in the next case, because there we have a neuroma without nerve continuity, the worst case, neurotmesis. The case is about a 17-year-old boy after car accident and cut due to glass fragments, the left side of the neck, And he was quite lucky because they found one glass fragment about 1 millimeter next to the carotid artery. So they had real emergency surgery there. And afterwards, he had a Tinel sign on the left side of the neck and function loss of trapezius and sternocleidoid muscle. During EMG examination, he fainted. So we did not have too much information there, but they told us they found signs of denervation in trapezius muscle. So we had to do the nerve ultrasound to assess the nerve continuity. And here, the introduction of the region of interest of this case. We have to detect the external branch of the accessory nerve. And from proximal to distal, we have the cervical root C4, the external branch going down to the sternocleidoid muscle, going through the sternocleidoid muscle and below the trapezius muscle. And in the images now, I will show you the other way around, from distal to proximal. And we can easily find the external branch of the accessory nerve next to the trapezius muscle. Then we can follow it in the direction of this sternocleidoid muscle and going through the sternocleidoid muscle, like here, and then go out of the muscle, and we are here again. And this is the region of the trauma in this case. So in the cross-sectional view, we could find a neuroma, an enlarged hypoechoic neuroma. The cross-sectional area was 8 times as big as usual. And in the longitudinal view, here's distal, here's proximal. We are here in the sternocleidoid muscle, and this is the nerve going through the sternocleidoid muscle. And here the neuroma is very well and very enlarged. And here we can find the nerve, and here's still the nerve, but here we have scar tissue, and we cannot be sure after this region what is happening here, and we cannot detect the nerve inside the scar. So I can show you this in the video sequence, and you can have a look on your own if you can find the nerve there. Here the nerve is going through the sternocleidoid muscle. Here's the enlargement, the neuroma. Here is the scar tissue. And here we can see nerve parts. But here we cannot be sure if the nerve is in continuity. So I sent this boy to the MR neurography, and they had the same problem. They could not detect the nerve within the scar, and they could not prove there's continuity too. And so Professor Antoniadis did the explorative surgery and found the nerve cut. It's like in our video, it stops here. And so he did a nerve interponate with a connection here and the other seam here. So as a conclusion, nerve ultrasound is a valuable method to detect nerve integrity. And in addition to EMG, it provides information about morphology of the lesion. And in case of motor loss and probable loss of continuity, we recommend surgical exploration and the opportunity of reconstructive nerve surgery. So my last case, last but not least, a tumor case. Nerve ultrasound is able to detect intra and extraneural tumors quite quickly and in early stages. Typical tumors are schwannoma, neurofibroma, perineurioma, malignant peripheral nerve sheath tumors. And this case is about an intraneural perineurioma. This is a benign peripheral nerve sheath tumor and is usually affecting young adults in a very important period of their life. And they have function loss. First, mononeuropathy, slow progression, but there's also progression in proximal parts possible, like brachial plexus, cervical roots, usually not entering the spinal cord. Histologically, there's a there's a perineural cell proliferation and pseudo-onion bulbs, and there is an association with deletions of 22q2. So this case is about a 23-year-old girl. She was diagnosed with intraneuropurinaryoma 3 years ago, and she had a complete paresis of the radial nerve function over the years. Now she had a new problem. She had a strange feeling of the left hand. And the question was if there's a progression in the brachial plexus, for example. And MRI, a standard MRI, did not find something pathologic, and EMG was also quite normal, only slightly affected. And I would like to show you in this case the character of progression of these tumors. It was a radial nerve tumor at the level of the upper arm, and now the progress is over the posterior cord, the superior and middle trunks in the cervical roots. And you can see here in the cross-sectional view the cervical roots between the scalene muscles. And in the video, here are the scalene muscles, and please focus on this region. Here we can see already the cervical roots enlarged, C5, C6, C7. I go down to the level of the supraclavicular part of the plexus here and back again. And so here we see the affected brachial plexus, the cervical roots 7, 6, 5 until they enter the neuroforamina. And so this is a case of progression. In the cross-sectional view, we can see here again the enlarged cervical roots with a plus of tissue reflexes within the affected cervical roots, and the cross-sectional area is 2 to 4 times as big as usual. And we can also see this in the longitudinal view, the enlarged cervical root and the increase of connective tissue between the fascicles. And the question is there a treatment? And the treatment of these tumors ranges from observation, because these are benign tumors with a slow progression, via interfascicular neurolysis to give the fascicles more space if the tissue is getting more and more, and to nerve resection and nerve grafting, which is preferably in early stages to prevent progression. And there are also cases where compression and entrapment due to anatomical conditions may occur, and operative decompression may be helpful. But here, the last word has not yet been spoken. And so in this case, nerve ultrasound provided the decisive information, and nerve ultrasound is able to do so in early stages. And so this is an opportunity for therapeutic perspectives. So I hope you have an overview about what nerve ultrasound is able to do and for what we can use it. And I hope you enjoyed my cases, and I thank you very much for your attention.
Thank you, Dr. Burchett, for sharing those really interesting case studies. It gives us a real sense of where and how muscular ultrasound fits within the clinical workflow. So we have some time now for discussion, and we can pick up some of the questions that have been coming in. But just before we go to the questions, I should also mention that both of our speakers this evening have extensive publication history with an impressive number of scientific publications as well as book chapters between them. So if we don't get to your question, or if this has inspired you to learn more, there's definitely no shortage of information out there. So let me just pick up some of the questions coming in. One of the first ones. So someone's asking, would ultrasound nerve imaging show nerve pathology before EMG?
I don't know if you have a preference for who answers this, but I think we will agree that it definitely does. So you can see damage to the nerve from day one. Even in cases with inflammatory neuropathies such as neuralgic amyotrophy, we find imaging abnormalities as soon as these patients come in, and they come in soon sometimes on day 2 or 3. Same with GBS in acute cases, trauma, obviously. So there's no need to wait. And that's one of the nice things, for example, in trauma cases. If the patient is in the ICU ward, it's often very difficult to get different types of imaging because of the transport risks. But you can just take the ultrasound machine to the bedside and do the scanning. So, yeah.
Perfect. Thank you very much. And maybe I can address this next one to Dr. Barsha. If someone's asking, is this technique also helpful to diagnose muscle tear?
To diagnose
just, a muscle tear, or just for the nerves?
Oh, I don't know. I'm not sure if I get the question right, but I guess Professor van Alphen also mentioned the muscle diseases where we can use ultrasound, and this is a focus of Nens van Alphen, I guess, to use it for muscle diseases. So perhaps you want to add something.
If you talk about muscle tearing, I think you're basically talking about MSK ultrasound. And it's a very commonly used tool, ultrasound, to diagnose muscle tears. So yes, definitely.
Great, thank you. And we also you showed in some of your presentations about measuring areas of the nerves. Someone's asking, what's the best way to measure the cross-sectional area of a nerve, with an ellipsis shape or with continuous tracing?
We have on the one side continuous tracing, which is quite exact. The ellipse is also very exact, and there's no significant difference. I guess, Nens, you checked this. And in the beginning, we checked if there's a difference between the crossing and the cross-sectional areas, the diameters, to have the ellipse formal, and there is no difference too. So there are different ways to have the cross-sectional area, and there are usually no significant differences.
I'd add from a practical point of view that the ellipse is faster usually. So if you have a nerve in view that you can actually fit an ellipse into, it's probably the quickest way. And it's been examined that it's not more or less accurate than the trace. But sometimes you encounter a nerve that has a star shape, or, you just can't fit that tool. So then you actually need to manually trace it.
Okay, great. Thank you. And on the subject of measurements, could you explain a little more the difference between population-based references and the disease-specific cutoffs, and how you would use those in practice?
Oh, can I pick this one up? Because that's one of my favorite topics. So it's not just for ultrasound, but we basically, as you indicate, there's 2 types of references. So you have a population, and you can measure a P95 or a P5. So if anyone comes over or under that particular number, it's very likely that they are abnormal in that measurement. And if you have nothing else, that's a very good way of saying if something is abnormal based on the numbers. But if you look at a very specific disease, such as carpal tunnel syndrome, there's been lots of research showing that in that population, you can create what's called a receiver operating curve cutoff value, for example, 11, 12, or 13 square millimeters. And every choice gives you a different sensitivity versus specificity. So then basically you can select whatever you want. Do you want to be very sensitive or very specific for that disorder? But please, whatever you do not confuse the two, because they are different. So people have come up to me and said, we use 12. Why do you use 11 square millimeters? Well, that's because probably you're using the population reference and we are using a disease-specific one. So as long as you're aware of the difference, I would suggest that if there is a disease-specific one for that particular patient you're seeing, then use that. And otherwise, just know that you're using a population reference.
Great, thank you.
Question, because I could go on.
Perfect, thank you very much. So another question here is, would you advise to use color Doppler when assessing entrapment of a nerve?
Alex, would you like to come in?
You can also answer.
Well, I don't do that standard, but it's very helpful if you're in doubt whether something, for example, is a nerve vesicle. Because, for example, the ulnar nerve in the upper arm always has this tiny little blood vessel that runs with it. So you need to not take that into the cross-sectional area measurement. But I think the person asking the question is probably referring to, can you see signs of inflammation in that particular nerve? And I think in a certain portion of patients, you probably can, but it's not nearly as sensitive or specific as that cross-sectional area measurement that we do. So in most cases, it doesn't really add much to do it. You can, and sometimes you see abnormalities, but you don't need it most of the time. Alex, do you use it in a different fashion, or?
It's more interesting, for example, to detect the persistent median artery or something like this, which could be interesting for the surgeon if it's something like this, but not for the entrapped nerve itself, usually.
Okay, great. Thank you both very much. So I guess maybe a little bit of a practical question. Someone's asking how long it takes to make ultrasound nerve imaging plus EMG.
For what indication?
Like
carpal tunnel syndrome takes me 10 minutes to do both the ultrasound and the EMG probably.
Okay.
But if you're looking at CIDP, full bilateral arm plexus, or even worse, mononeuritis multiplex, vasculitis, you might be with the patient for an hour and a half just for the ultrasound. So it really depends on what you're looking for.
Okay, huge variation then.
Yeah.
So one question, I mean, I think it's quite clear that both your presentations have, as your title suggested, shown that they're game changers in diagnostics. So what are the barriers to including neuromuscular ultrasound in routine clinical practice, as it seems such a sort of perfect fit?
Alex, I'll have you go first. Depends on the country as well. So
okay.
The barriers of nerve and muscle ultrasound, our limits.
Yes. In terms of adopting into routine clinical practice.
Why is not everyone doing this already?
Yeah.
Yes, there are a lot of aspects, I guess. It's depending on the experience of the examiner. So you need time to learn this. You need an technical, you need an ultrasound application which is able to see nerves. So we have probes 15 megahertz or 18 megahertz to see the fascicles. And in trauma patients, for example, it's a question of time too. It's a logistic question and a question of payment. And so I guess there are a lot of barriers of nerve and muscle ultrasound, but it's getting more and more, and the benefit is shown, I guess. And so the conditions will be changed step by step to make this possible, because it's a quite useful and diagnostic tool, and in the everyday routine you could use it quite quickly at the bedside. And so this is sometimes a very very good aspect compared to MR or CT or other diagnostic tools. Perhaps Nancy, you can add your barriers.
Yeah, so I think you identified some very important ones. You need time to learn, but then you also need time to scan, because you need to do this on a regular basis to get experienced and keep your hands on, the fine finger movements, as we call them, for this. But I think in a lot of countries, financial reasons are a big limit, because neurologists often are not able to get paid for this exam, as it's not traditionally within their scope. And that can be limiting. In the Netherlands, for example, we are lucky that we have a different payment structure where we can actually just bill for the ultrasound as a separate exam. But in the US, it might be that the physician can only get like $10 for an hour with the patient, which is ridiculous. So there's a large difference there. And the machine is one thing. And then we always say, okay, can't you share that machine with, I don't know, the anesthesiology or the ER or whatever? And it's never convenient. So you really want some equipment of your own. And I think one of the big possibilities here is the advent of the portable, but really, the scanner that is handheld. You can put it in your hand, put it in your pocket, latch it onto your iPhone or laptop. And these are already on the market. And they make it really convenient for you to take that probe to the patient and scan whatever you need to, whenever you need to do it. So I'm sort of looking forward that everyone gets one of those in their stocking for Christmas next year and start scanning on a regular basis.
Perfect. I mean, I think the question there shows that you've sold the audience on this being the answer to the problem. So that's great in itself. Someone else asking here, what about elastography and the diagnosis of nerve disease? If either of you have comments on that.
It's, I know that some research groups are looking into it, and it's difficult.
It's in progress.
Yeah, so it's a really difficult structure, because a nerve, I mean, like if you do an elastography of a muscle or even a liver, for example, that's a static organ. It's always at the same spot. But a nerve is actually going through all of your limb in every direction. For elastography, you need a segment that is sort of linear. You need to be able to get a certain scan angle to it, which is already difficult if you're running into the carpal tunnel, for example. And it's real difficult to standardize what you're doing in that respect. So there are a couple of groups who are doing it, but it's really early stage. If anyone is interested, I would suggest they get in touch and start doing it too, because we want to know if it's useful or not.
Perfect. Thank you very much. So if we pick up another question here, can we detect myelin sheath degeneration through ultrasound imaging?
You mean like just demyelinating nerve segments, which would show up as slowing on EMG?
I'm assuming so, that in terms of the detail we've got for the question, but yeah.
Maybe you have. So Alex has shown us one of your probes with a 33 megahertz frequency. And there are probes out there that go up to 70 megahertz. So you can only image 4 millimeters beneath the skin, but they have fantastic resolution. And it's sort of like looking into the body with a microscope. And then still you are able to see fascicles, but you're not able to really discern the individual axons with a myelin sheath. So I'm assuming that if you would have a, I don't know, 150 megahertz or something transducer, you could do that, but then you would need to take the skin off and put the transducer directly on the nerve, which is not as bad as it sounds, because it might be used intraoperative.
Intraoperative, yeah.
To see if you've sewn the fascicle together in the correct way. And there are groups I know in the US that are considering doing that in the intraoperative situation.
Wow, fascinating. So we're getting quite close to being out of time, and I'd maybe like to finish and ask both of you the same question, just given your clear, genuine passion on the subject. And perhaps, Professor Van Alphen, you've already hinted towards this in terms of your stocking gift suggestions, but I want to ask what excites you most about the future of neuromuscular ultrasound as a tool in your practice?
Ooh, for me, the most exciting is, and then the stocking with the gifts just helping. I would love to see every neurologist in a general practice having access to this tool for, the patients they're seeing. So if you're only seeing carpal tunnel, fine, but then use it for that. And if you want to do more advanced stuff, but know where to find your education, be able to find time and reimbursement for your efforts. So I hope in 10 years, the neuromuscular ultrasound part will just be a standard part of the training program in neurology, basically, and it will be normal for people to have that exam. That will be a dream come true.
Yes, I agree. And I guess we are in the beginning of it. And while doing ultrasound, we see how much more we can detect and how much more security or therapy perspectives we can get with the help of ultrasound. This is the right direction.
Perfect. Thank you both very much. And I'm very excited to follow the progress in this field. So I would like again to give my thanks to both Professor Van Alphen and Dr. Borschut for these fantastic presentations and for the discussion. It's been so fascinating to learn about this emerging diagnostic subspecialty, and it's so especially encouraging to hear not only how it benefits you as clinicians, but also the impact incorporating this into your practice has on patients. Now, that really was the perfect way to round out our online neurology days. With these sessions, we wanted to be able to showcase the best of neurology. And I hope you all agree that the experts we've brought together over the 5 days really are the best in neurology. We spent 3 days following an acute stroke pathway. We took an in-depth look at multiple sclerosis. And tonight we also diverged to the peripheral nervous system. The common thread that ran through each session was that in all of the advances we can make technologically, the ones that really matter are those that make the difference to the patient. So on behalf of Canon, I again would like to thank all of our speakers over all 5 days for showing how what we do matters. And I'd also like to thank all of you for taking the time to join and listen to what we have to say. I really do hope you enjoyed our online neurology days as much as we did. Thank you all for joining.